The TMJ TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Hello, TMD warriors. It's another Tuesday morning, and we are gathered here for the next episode of TMD Demystified. I am Tony Urbanic. Today, we're going to continue on with the topic that I had been talking about the last few episodes, which is value-based TMD, TMJ treatment. Value-based. Based on a textbook, which I will get again. Excuse me, to give full credit to Dr. Robert Pearl, who I was very impressed when I read this book, and I'd suggest it for anyone who's interested in healthcare, particularly your body, your medical health care. But we are all dental healthcare providers, specifically one way or another. I, as a maxillofacial surgeon, oral and maxillofacial surgeon, walk both rails. That has been the privilege I've had throughout my career, having both dental and medical degree. So I watch and listen to and learn from both sets of colleagues in the dental arena industry and the medical arena and industry. And I was very impressed by reading Dr. Pearl's book, who talked about value-based medical care, which definitely applies to dental care, which definitely applies to TMD, TMJ care. So I'd recommend highly that if you're interested in some truth about what really is going on in the medical industry, I think Dr. Pearl paints a exceptionally honest picture, and he's believable because of his experience running Kaiser Permanente clinical division with, I believe I recall him saying, over 10,000 doctors, that he was the CEO of over that group for 9 years. My God, that's a lot of responsibility, and he paints out the problems that he had. But I won't give away the textbook. The book itself, and I'll let you read it if you want. But we are applying a little bit of those concepts that Dr. Pearl brings out as it applies to TMD and what he calls value-based treatment. In this case, value-based TMD treatment. In part 5 of this episode will be sincere and compassionate provider service delivery. So if you can provide, as a medical provider of any kind, you can provide a service. You can provide however you define that service and however you want to define that service according to your ethics and morals and the requirements of the government and the requirements of your training program and the requirements of your local board, all the requirements that we have to meet, licensing and training and continuing medical and continuing dental education. And we work hard. I think most of us in the medical dental provider arena work very hard to do all of those certain steps. And some of us don't. And the ones that don't are the ones that get most of the visibility, unfortunately. It makes it seem like there's a lot more doctors and other providers who go way outside the norms. But I know that the majority of providers out there are trying to do the best they can. But when it comes to providing the service, the concept, if I haven't made it clear, is providing a value-based, not just, can you provide that particular service, but does that particular service have value, and how much does that particular service have value in comparison to other competing services? The most common, or the most significant in my arena, which has been played out in my experience in my entire career, almost 50-year career now, is the value when it comes to TMD of the value of surgery versus non-surgical treatment. It's just a really good example that sticks out in my mind. You could think of literally hundreds, if not thousands, of other opportunities and treatment for patients of one variety or another, and the relative value, which is what patients need, what patients want. They want to have a service or a system that has the most value to it. And another example would be, whether it be physical therapy or chiropractic in comparison to surgery of the bones and joints. And that's a very dicey topic, and it can be debated in many different ways. But we're just going to stick today to, as always, to the concept as it applies to TMD, TMJ. So what I have experienced, and I'm going to speak on, and again, I invite any criticism or comments, of which I get none, I must say, even though I'm ready and willing to discuss and debate or communicate with anyone who would like to comment on my topics and my point of view. I get none. And it is surprising, after 137 episodes, one a week, for the past 2.5 years. Today is episode number 137, which I will discuss some of these competing treatments for the treatment of TMD and their value, and whether or not that value includes sincere and compassionate provider service delivery, because value can be dissected or divided into certain concepts, and the concepts that we've covered already were a high degree of documented successful clinical treatments, how well it works, simple transparency of the treatment, excellent patient compliance, minimal side effects and unintended consequences, and today is sincere and effective service, sincere and compassionate service. All right. So what I have observed, get into this, and we won't belabor it too long. And I'm going to call out some characteristics. I'm not going to call out any people, but I will call out characteristics that I have observed. And I've got a list about 1, 2, 3, 4, 5, or 6 that are not sincere and compassionate when it comes to TMD. And honestly, I have noted over the 50 years since I first started being trained in the treatment of TMD, first surgically and then on my own initiative non-surgically, most of the providers for TMD have not been very sincere or compassionate about treating these patients one way or another. The first one that comes to mind, I'll tell you the story, and this is very common, but my own experience, and I'm pulling all of this together, these 6 concepts together. Some of them I've spoken on before, but the Botox is a treatment that I hear even constantly. As of yesterday, I had a patient come in. She was doing very well with her intraoral device and non-surgical treatment with the Urbanic device and protocol, and her degree of symptom relief was in the 80 or 90%. But she even asked me, what do I think of Botox? And I told her. I told her what I think of it. I told her my experiences. I told her that I had a patient who, over 10 years, had spent $200,000 on Botox between her and her insurance company, $200,000. And this was a patient, after $200,000, was sitting in my office and eventually got relief using a intraoral non-surgical device and gave up the Botox. I had another patient, I think I've spoken on before, a young woman, a very young woman, who had access, worked for a plastic surgeon and had access to these medications. I don't know the particular brand name, but she had multiple areas of the face and jaws that had pain from what turned out to be obvious TMD. And she had her entire face Botox where she had no wrinkles and it was just shiny skin, but couldn't smile. It's just, and then the one that really I need to discuss is sitting in a lecture with my fellow oral and maxillofacial surgeons. This was a while back. This was when Botox was first started trying to be used for the treatment of TMD, which, by the way, those medications are not approved by the FDA for the treatment of TMD, TMJ. But I was sitting in a lecture where one of my colleagues went on to how to use Botox, what it was, how it was somewhat effective. You paralyze an area of the face, and that face is hurting. Muscle's not going to get tight anymore. But at the end of it, she went. It was a female oral maxillofacial surgeon, went through the summary of what she had talked about, and then the last point was the best part about Botox was the patient is always back in 3 months. And she kind of giggled, but nobody in the room giggled, and I thought it was an offensive remark. Which, I mean, perpetrated a degree of lack of sensitivity, compassion, and even ethics as to the best part of that treatment as the patient continues to come back for the treatment, which inferred, as it was an definite inference, that there was more money to be made. It's like, so, and that's just one example. And because the Botox people do so well at promotion and advertising, it seems to be well accepted and well promoted, extremely well promoted, to the point where very frequently people come in and do a consultation with us, either myself or my associate, and they ask about Botox and what we think about Botox. And it's, so that's not a very compassionate and sincere way to treat a TMD problem and patient. Next one that comes up again in this same category is the use of night guards. Now, I have gotten introduced to night guards way back in the early mid dental school. Let's just say 1971, 1972, 1970. And where I went, got my dental education, was Indiana University, and there was a department called oral medicine where anyone who had unusual facial pain, jaw pain of any kind that was not dental pain oriented went to oral medicine to try to figure out, well, where are these pains coming from? What can be done about it? Which is a valid department and a valid reason to look. But way back then, it was the standard of care if the departmental chairman or one of the other professors thought that the problem was temporomandibular joint oriented for any reason, treatment of choice was a night guard. Even as a non-graduate dental student, and I saw these night guards being handed out, I couldn't figure out, well, how, if you have facial pain, how covering the surfaces of the teeth are going to make that facial pain or jaw pain or pain on chewing or noise within the joint or whatever that their criteria was for treating, how covering the surfaces of the teeth with a piece of acrylic was going to solve that problem. And actually, on only one occasion, I asked the question, how that works. And the professor in the room at the time gave me a very brief brush off as a no answer answer. And by that time, I was kind of schooled into recognizing what a no answer was, and I was not foolish enough to push it any further. And I would recommend all you out there to be able to recognize a no answer, and when you're being brushed off, don't bother pursuing it. You're not going to get a better answer the next time. You'll need to look elsewhere for your answer. In this case, I was a young dental student and I did not want to rock the boat, and I just let it be. But I very carefully remember thinking, how does this work? And I didn't find out from my professor, but I went on to, my goal was to graduate, and so I did. But when I came out into practice, and after I did oral and maxillofacial surgery for internship residency, went through medical school, and did a 2-year stint as a fellow with the NIH in research project and PhD program, I continued to see, when I had the opportunity before I came in private practice, the use of night guards for the treatment of TMD. And then when I came in private practice, I saw that it was pandemic. And here are the numbers, and no one has disagreed with me, and I've said it multiple times, and no one has checked me on it, fact-checked me on it, called me on it, wanted to discuss it. But 50% of the dentists, when they're faced with a patient with TMD, TMJ, make a night guard. And 50% don't want anything to do with the TMD, TMJ patients, except for the 0.1 or 0.2% of the dental profession who tackle the problem for better or for worse. We're going to talk about the worse in a moment. So it is usual and customary in our environment in 2024, it is now February of 2024, for 50% of the dentists who think they have a patient in their chair or in the office with TMD problems to make them a night guard and to give them that treatment, knowing one of two things: either that they have no idea how it works, but that's what everybody does, which is the majority of them, I believe. Now, that's a belief. I believe the majority of the dentists make that night guard because that's what everybody else does. And a percentage of the patients, of the doctors who prescribe and utilize a night guard for the treatment of TMD, know it's not going to work, but give it to the patient and hope the patient doesn't come back, and just give it to the patient so they get the patient out of the office. And that is the general nature. No one says, no, I've said that to hundreds of dentists, what I just said. No one has disagreed with me when I talk to a dentist about that. In fact, I get a lot of head shaking positive, truly. And then the 50% that, because they know that night guards don't work, and they know that night guards are the treatment of choice, and nobody really knows how they work or how it's supposed to work, they don't want anything to do with TMD patients, because that's basically all they have to offer the patient is a night guard. So they go, these are difficult patients. I don't want anything to do with them. Go elsewhere. If I know somebody else who treats TMD, I'm going to give you their name. That is not sincere and compassionate treatment. I mean, if you're a dentist, you may not, I have no problem if you can pick and choose what kind of treatments you want to do. And you can pick and choose your patients. You do not have to treat everybody that comes in the door. And a smart doctor learns sooner or later that some patients are beyond either his technical capability or his emotional capability to deal with some of these patients. And you have the absolute responsibility and right to do that. But you don't have the ability and right not to be compassionate and sincere in your treatment. So for those doctors who are listening at any time in the future, you know what I have my opinion about night guards are, and that they are not a compassionate and sincere treatment protocol. A similar one that is recommended or prescribed, both a similar kind of thing, it's prescribed mostly by oral and maxillofacial surgeons, but also by general dentists, I guess because they're either instructed by or knowledgeable that the oral surgeons prescribe muscle relaxants. And again, it's the same concept. It's the exact same concept. In my training at Vanderbilt, in oral and maxillofacial surgery intern residency, we dealt with a lot of TMD, and my mentor, Dr. David Hall, who's an icon in the field, he worked extremely hard to try to develop a surgical correction, a surgical assistance for temporomandibular joint problems. I won't go into that. It's all in the literature, and I admire him for what he did. But honestly, it didn't work out. And that is why in my career, mid-career, I gave up trying to do surgery for the treatment of patients with temporomandibular joint and did my own research to see if I could figure out what no one else was looking at. I knew that surgery was not the solution for sure after 2,000 cases. It took me a long time. But I tried everything. I did everything multiple times. There were some things that were more valuable than others. We definitely had some success with surgery, but 30 or more % of the patients were back. So surgery, I decided, was not good, but the use of muscle relaxants was the same concept that we used in oral maxillofacial surgery that the general dentist used as night guards. We knew that muscle relaxants were not a long-term solution. Most of the time, they weren't even a short-term solution, and we knew that the side effects from muscle relaxants, the patients complained about them all the time. But in my training, that was the standard of care at that particular teaching institution, as it is in many other teaching institutions. I'm not picking on Vanderbilt. I think that applies to probably pretty much every oral and maxillofacial training program in the country. That may not be the first line of defense, but it's high on the list. And currently right now, I am absolutely knowledgeable and experienced with a patient who goes into Vanderbilt, and they will be prescribed without any hesitation a muscle relaxants as first line of defense. And then if that doesn't work, if and when that doesn't work, and if the patient comes back with future complaints, then they may, depending on circumstances, go into a much more complicated workup, MRIs or CT scans and a big workup, and possibly put on the lineup for temporomandibular joint surgery. So, and again, we know, and I know the doctors currently, whether it be in a teaching program or in a private practice institution, know that muscle relaxants are not a long-term solution, but yet they give them. Question is that sincere and compassionate service? Is it value-based? Are they doing a value-based service that is sincere and compassionate? And I say no, it's not. Dentists are the only people, whether it be dental specialists or general dentists, we are the only people that have the basic knowledge of the dental mechanisms, the maxillofacial masticatory mechanisms, trained highly to treat it, and have the basic knowledge that we can treat TMD, TMJ successfully. So as a dental provider, you have a certain responsibility. We talked about you don't have to treat the patients, but we are the only ones who have the potential. The medical doctors do not have the potential to treat these patients. They don't have the potential to take impressions. They don't have the potential to know how the different classifications of occlusion, how occlusion and jaw growth, which should be, if it isn't, an intimate part of orthodontic training, they're not privy to all this information. They're too taken up with their own areas of medicine, whether they be generalists or specialists, and it is left to the dentist to do it. And those that try to do it and fail to do it, and then complain because they can't do it, or denigrate the patients because they can't do it, which I've heard multiple times, is not sincere and compassionate treatment. So the objective here is to bring it to the attention of the listener, you, right now, and to consider what is value-based, which has versus what has less value, and brings me to one of the final points, and that is the dentists, and primarily the physicians, more heavily weighted to physicians, who do denigrate patients because they think they're crazy when they have all these odd symptoms and they can't explain it. Good example just came to mind. Yesterday on Monday, I see patients, and I had a patient who had been seen by two dentists, an endodontist, and of course her PCP, with complaints of jaw pain. The original two dentists couldn't explain it. They thought the teeth were okay, but the second dentist eventually ended up, because the patient kept saying it hurts right there, it hurts right there, eventually ended up taking out the tooth, the quote offensible tooth. Taking out the tooth, the pain continued. He then replaced the tooth with a dental implant. The pain continued. They couldn't figure out, they thought it was tooth number 19, but it could have been tooth number 20. So tooth number 20 looked okay, but eventually, because the patient kept saying pain is right there, the patient was referred to an endodontist. The endodontist did a root canal on tooth number 20, and the pain continued. At which point the endodontist said, there is no nerve in this tooth. This tooth can't possibly be hurting you, and sent the patient to us. And the patient, after a very simple, very simple history and physical examination, pushing on the jaw joints from the open to closed position, the joints were hot, painful when you did that. The symptoms were there, pain there, but also a history of headaches and neck pain. I think the patient also had a history of subjective hearing loss and vertigo, obvious TMD, and she is now under treatment for TMD, where the whole process was misdiagnosed and mistreated. But that's not the point. The point is, was that there enough sincerity and compassion to look elsewhere when the original two dentists who treated this patient, they couldn't find anything wrong with the tooth, but they went on to treat the tooth or recommend that the tooth be treated with a root canal, at which point it only broke down when the endodontist who treated the tooth said, this is not tooth pain. It's got to be something else. The question is, was that sincere and compassionate by those doctors? It's okay if you think I'm trying to beat up on doctors of criticism, which I'm not. I'm trying to bring it to your attention. And the final concept is that 0.2% or less of the dentists out there who actually have a practice, partially full-time or part-time, and promote themselves as treating TMD, but try to make it complicated, try to make it complicated for their own benefit, for their own practice benefit, rather than trying to make it simple or easy or more less expensive than the thing that they're doing. Because again, the objective is value-based. How valuable is it versus the other opportunities. One of the things that I saw several times in the trade literature or on the internet was the doctors that I called TMD gurus, and I stick by it, who actually have meetings or online courses to teach you how to game the insurance company by using different medical codes, CPT codes. This is a medical problem for sure. It's not a dental, it's not covered under dental. TMD is not covered under dental. If it has any coverage, it's going to be covered under medical. The medical insurance companies don't want anything to do if they have anything with TMJ, TMD. They're forced to, quite often, if you do surgery on the temporomandibular joints, if you have a non-surgical treatment of a temporomandibular joint, they just basically tell you it's not covered unless you learn how to game the CPT codes, which the TMD gurus, for great part, probably not everyone, but they have meetings to teach each other how to game the insurance companies by coordinating or knowing the right CPT codes to use, which I question highly whether that is some sincere and compassionate treatment. My belief it is not. So I bring this to your attention because the objective is to provide a service that is sincere and compassionate, that is as simple as we can make it, rather than to take a 2 or 3 hour consultation doing all kinds of things so that you can supply a medical reviewer a half inch of paper that they can review that sounds important. And I think they think that that's going to make a medical reviewer think they're important because they can supply a ream of paper that goes along with their recommendation for whatever it is. I don't think that is sincere and compassionate provider treatment. So I say this as a little wake-up call. If it wakes you up at all, it may not wake you up. You may think that I have different motives, but not. My motive is to bring these things to your attention, for you to evaluate it for yourself. What's real to you is real. If you see it for yourself, it's real. Take a look around on this topic of TMD, TMJ, and how it has been treated by the dental community. We're the only ones who can treat it successfully. And make up your own mind whether what you see out there is sincere and compassionate treatment, or whether it is, for one reason or another, one degree or another, whether it be through interest in increasing patient volume or increasing patient revenue, or just decreasing the patient's volume and getting them out of your space, whether any of those things would fall under the category of sincere and compassionate. With that, we're going to end it. I look forward to comments, criticisms. I can be reached at tony@tmjservices.net. If you'd like to join our network of providers who use what I have discovered about TMD, the actual discovery is it's all generated by inflammation within the joint. If you make the inflammation go away by unloading the joint adequately over a long period of time, using a device and protocol, very simple to diagnose, very simple to treat, does not take a long time. Patients are very, very, very happy when they get their 10, 20, 30 years of pain, discomfort, and symptoms gone. You can learn all about that at www.urbanictmj.com. Our director of marketing, and also Naomi Williams is our director of operations. She can be reached at naomi@tmjservices.net. Until next time, I look forward to the next time I get to speak with you. We're going to finish up this topic on the next episode. and I hope you have a very successful and productive week. I am Tony Urbanic, and this is TMD Demystified.